Welcome to AETCM, the Emergency Medicine Channel.
Yeah.
A 63-year-old female presented to the ER with complaints of acute onset abdominal pain of 4 hours duration. On our initial 10-second assessment, patient was conscious, oriented and obeying commands. Coming to the primary survey, airway, no pooling of secretions, no gurgling, no hoarseness of voice. Coming to breathing, respiratory rate of 25 per minute, saturation of 97% in room air. Coming to circulation, BP of 140/80 millimeters of mercury, pulse rate of 80 beats per minute. All peripheral pulses were equally palpable. 2 large bore IV cannulas were inserted during this point of time. Coming to disability, GCS of 15/15. Bilateral pupil equally reacting to light. Coming to exposure, 99.2 degree Fahrenheit with a GRBS of 120 milligram per deciliter.
Pain score?
The pain score at this point of time was 6/10 and injection PCM 1 gram IV stat was given at this point of time.
Okay. So basically we have a 69-year-old female, otherwise stable, who has come with a simple history of 4 hours history of abdominal pain. So that is the only history that we have. So now you can just go ahead with the quick examination of the GI system.
So detailed history.
You can just sell a sample history and you can go to it.
Coming to sample history, a 63-year-old female, known case of osteoarthritis and type 2 diabetes, presented to the ER with complaints of acute onset abdominal pain of 4 hours duration.
Okay. Now my question is, with this background, osteoarthritis and diabetes mellitus, somebody is coming with abdominal pain. As a general physician, you are not just, don't think about emergency physician. As a general physician, what are the differentials that you will keep that in your mind?
So one is patients in known case of diabetes can be a DK which presents with abdominal pain.
Okay.
Then other things can be like osteoarthritis, drugs that can cause gastritis.
Yeah, that's what most importantly. So you have to just see that this lady, osteoarthritis, so they might be on calcium supplement. Maybe somebody would have prescribed her some NSAIDs. So these things are very prone to develop this gastritis. And again, DK is one of the differential that we need to consider. And maybe an acute MI also. That is that as an ED physician, we will definitely consider. But as a general practitioner, always keep that whether the patient is taking any metformin. So that history has to be very, very clear. So metformin-induced gastritis is a very frequent presentation to the emergency room. So it can be just simple metformin-induced gastritis, 4-hour duration. So that is a background that you need to have some simple things, what drug she was taking, any aspirin, all those things will increase the risk of having an acid peptic disease and gastritis. Okay.
The pain she described was like a constant burning type, mainly in the epigastric region. There were no radiation. There was associated vomiting, 3 episodes, non-projectile, contains food particles. No history of any constipation, no obstipation, chest pain, syncope, fever, no other aggravating or relieving factors. The patient also gives history of on and off periodic nature of the pain that increases with acid and spicy food and decreases on alkali intake.
Okay. So there is definitely history of gastritis. Some acid peptic disease is there for
her. Medical history, the patient was on metformin BD for type 2 diabetes mellitus. For osteoarthritis, the patient was taking on and off painkillers, NSAIDs without the prescription of the physician.
That gives us a suspicion of whatever diagnosis we were suspecting. So whether it is a simple gastritis or whether it is something complicated with gastritis, that is only our question in differential that we need to keep in our mind.
Coming to the last meal was taken at 2 p.m. Coming to systemic general examination, no pala, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Coming to systemic examination, GIT, the patient was examined in supine position with legs extended and adequately exposed after taking the consent. Coming to inspection, the abdomen appears distended, no discoloration, pulsatile swellings, dilated veins, scar marks, no visible peristalsis.
Can you just go to the palpatory findings?
On palpation, there were tenderness not in the epigastric region and there were associated guarding was also present. Coming to...
Okay, not just tenderness, there was associated guarding. So what does guarding indicates?
Guarding indicates there is an underlying parietal inflammation of the...
So it is not just a simple gastritis. So when it is just as guarding is present, then we have to think that peritoneum is involved. So we need to keep little bit as extended to our diagnosis, whether any complication to that acid peptic disease has caused her. So that will be our next path. Okay.
Coming to percussion, there is obliteration of the liver dullness were noted. The liver dullness was replaced by a resonant note over the area of liver dullness.
Okay.
Coming to auscultation, the bowel sounds were present.
Okay. So, as an ED physician, what will be the next steps for the management of this patient?
So based on this history, we were having a point of care ultrasound with us. So initially we did a USG, and that shows some hyperechoic areas suggestive of air bubbles.
Around the?
Abdomen.
In the abdomen. So there was some free fluid with some air bubbles seen in the ultrasound. So the first thing what you will give instruction is to keep NPO to this patient. You start some IV fluids. You have started already 2 large or IV access. Pain management you have started. So when you have a point of care ultrasound you can do, but the next investigation you have to go ahead with an X-ray abdomen erect and then chest X-ray supine position. So whether it was taken for her?
Yeah, then we went ahead with the chest X-ray abdomen, and it has showed air under the diaphragm.
Okay, so there was a gas under the diaphragm. So whenever you have a gas under the diaphragm, that means there is somewhere there is a rent in the viscera, and there has been some gas leak causing a gas under the diaphragm. So whatever from the history that we got and the clinical examination, whatever we have done, we had always had a suspicion of probably a peritonitis with a perforation, because she has a higher risk of taking NSAIDs in between metformin for a long time, and she has this history of acid peptic disease history she was giving, and somebody coming with an epigastric discomfort, and also on examination there was a guarding that you could recognize on, and there was some liver dullness was not palpable. It was a resonant note. It was replaced. So all those things was fixing into some pathology, and also ultrasound was proving that there is some gas bubble inside the abdominal cavity, and also an X-ray confirmed that there is a gas under the diaphragm. So at this juncture, what will be our next step?
Our first thing is to keep the patient under NPO.
Okay.
And then next step has to be put a Riles tubes.
Okay.
To decompress excess air in the stomach. Then we have to give the adequate analgesics for the patient.
Okay.
For pain control.
Okay.
Then IV fluids for the patient. Ideally, we have to dehydrate the patient.
Yeah.
Then IV antibiotics if we are suspecting a peritonitis or sepsis.
Definitely, we are suspecting a peritonitis in view of water. So, what antibiotics you wanted to use in here?
We need a gram-negative and anaerobic coverage.
So, we need to have a gram-negative, if cefuroxime, ceftriaxone, whatever be it, it's a gram-negative coverage with an anaerobic coverage also, preferably metronidazole, because it is below the diaphragm. Preferable agent is metronidazole. Okay.
Then we have to plan for a CT.
Now we have to confirm the diagnosis, where exactly is the issue, whether she needs an immediate surgical correction. Definitely she requires a surgery. So where we should know whether it's a peptic ulcer that has got eroded or something else, or a duodenal ulcer. So we had proceeded with a CT for her.
Sir. That showed a peptic ulcer perforation. Sir.
So it was suggesting a peptic ulcer perforation. Okay. And she was taken to the
OT for laparotomy.
Okay.
And done the omental patch repairs.
Omental patch repair. Okay. So it's a pretty straightforward case, that patient presenting with abdominal pain. So what are the most common presentation of acute abdomen in an emergency room? Sir, can you just briefly say how will you evaluate a patient coming with abdominal pain in the ED?
So one is based on the history, the onset, the duration, all the history and the associated symptoms. Abdominal pain, we from the ED aspect, we have to rule out inferior wall MI, especially in diabetic patients. We need to think about inferior wall MI, so we will take an ECG.
So just take the anatomical landmarks. You just go ahead with the epigastric discomfort. Start with the epigastric discomfort. As you said, the life-threatening one, what we suspect is an acute myocardial infarction, followed by an pancreatitis, then acute gastritis, like a peptic ulcer disease. Then what will be the other epigastric discomfort? What else they can present with? Decay. That's what you have said. Medical cause, you have to think of decay. Now coming to the right hypochondrium. What are the causes for right hypochondriac acute abdominal pain?
Cholecystitis.
Most commonly cholecystitis and hepatitis. And maybe an amoebic liver abscess. That all should be a lower down your differential. Going to the left hypochondrium, what will be the differentials?
There can be any collection abscess, like collections can be
splenic abscess, splenic infarction. The patient is on some anticoagulation and already known atrial fibrillation, so they can come with splenic infarction. All those things, post trauma, whether it's a splenic collection due to hematoma, all those things you need to consider. Now coming to lower down, what will be the other differential that you need to come? Go to the right lumbar and left lumbar regions.
There can be iliac fossa, we can look at the
Lumbar regions.
we can look at any
The most common one will be your renal stones. Urolithiasis. Then coming to the right iliac fossa,
there can be appendicitis.
acute appendicitis, and in a female, always suspect ovarian pathologies. Left iliac fossa,
In the females, we can say ovarian
diverticulitis. Again, diverticulitis. Then anywhere in the abdomen, you have to think in terms of an intestinal obstruction, or you need to think in terms of an aortic pathology also. You need to have an aorta beneath that, so aortic pathology. So depending upon that, you need to have a differential diagnosis. Then always have an examination of your genitalia also. So that is very important, because a torsion testis, they can come with abdominal pain. So always, whenever you are concluding your abdominal examination ideally should start from the oral cavity. You should look in for all your genitalia, hernial orifices, bleeding, PR examination, then supraclavicular lymph node. This all only constitutes your abdominal examination. So these are the common differential. So the most important investigation, when you ask me, is the ultrasound abdomen, which can be done on a bedside basis. And always remember ectopic pregnancy in a female childbearing age. When they come with an acute abdomen, always consider ectopic pregnancy as a differential. Simple urinary tract infection, low down simple UTI, all these persons can have with an acute abdomen. But here this lady was having a clear-cut history, and everything was pointing towards a peptic ulcer, which we diagnosed as a peptic ulcer disease, and she went on with the surgery. Okay. Anything else that you need to add on?
No, sir.
Okay, fine. Thank you.